cost performance category. How do we improve there?
You probably have the least immediate input into the cost category. It counts for 30% of your MIPS score. A loss or forfeiture of all 30 points makes it impossible to be above that 75-point performance threshold to be in the positive incentive range. So it's an important category. The cost profile in your system is deeply rooted in the training of your providers, your local traditions and expectations of your patients and the population, local peer pressure. It's hard to change those factors, even if you know what needs to change. It's hard also to check this category frequently to monitor your results on the fly and the results of your efforts to change this. You can't do it from your own claims. That is your own work. You have to do it from an insurer-sourced comprehensive claims data set. And it can be done, but it's hard to do. It's tedious to get it together. It's tedious to get it to get agreement from all the insurers that you deal with. Even hard for any one particular. And of course, the most important of those is Medicare. Two techniques quickly come to mind for you to address your cost scoring, even without optimum access to your data. One is the generic, I expect these techniques to reduce healthcare costs. There's a lot of clues to this you can find in the literature. There's a lot of there's ongoing research being done in excess of cost, variation of cost from area to area. You can make some meaningful changes on common sense type of decisions, even if you can't be guided by ready access to the data. The second technique is strategic decisions on cost participation. That is your cost measurement. The one I have in mind is it might be useful to you to choose to do MIPS value pathways, that's MVPs, to select or limit your cost liability. Now, to explain, be guided first by your historic cost scores. Medicare has access to its own comprehensive sets of claims and calculates annually its own cost measures. Most of us have access to those annual measurements through our feedback reports from Medicare, issued annually in usually late summer. Most of us deal with enough volume that we can expect some statistical stability in our cost profiles from year to year. They usually don't move much without deliberate effort on your part or a major local event of some kind, like a COVID pandemic. Now, look at your cost scoring in your feedback reports from CMS for the last few years. It's a good bet you'll see some stability. If your cost profile is naturally comparatively good, half of people, after all, are above average, you can put more of your attention elsewhere. If your profile isn't good, the half that's not above average are below average. Launch an effort to bring your cost profile down. But recognize in the short run, it's likely to be more achievable to maximize scores on the other three performance categories. So really put your attention into quality, promoting interoperability, and practice improvement. Now, I've talked more specifically about containing costs in past episodes, and I'll do it again in the future. It's not my intent today to get too far into the weeds on this topic. Be guided by the literature. I particularly like the work behind the Dartmouth Atlas, which deals primarily with unexplained differences in healthcare costs from region to region. And there's a number of other researchers and research organizations that put most of their attention into the delivery of care, not the science of care, and things that go into the cost of care. Also think about participating in MIPS value pathways. In the 2025 performance year, you can still use an MVP to score your entire multi-specialty practice. That option won't be around indefinitely. It had been projected initially to expire for that 2025 performance year, when to use MVPs, you would be required to divide into subgroups. But CMS did not choose to set that restriction for 2025, and it's uncertain at this point when they will. Keep watching it yearly, and until then, you can use an MVP to qualify your whole group. And with a choice of an MVP, you can limit your cost measure, your cost analysis exposure. In traditional MIPS, Every practice is evaluated on all cost measures for which they have adequate case minimums. In MVPs, a practice or subgroup using that MVP is only judged on the cost measures included with the MVP. Choose wisely. If you're not going to score well in cost for an MVP that you are eligible to submit, that MVP won't be a good choice for you. You'll not get the good score that you want. Now, stay tuned. I'll dig into this with more specifics and more references in a future episode. In the meantime, I'd be delighted to hear from any of you if you've used an approach that brought your cost profile down for you. I'd love to be able to share that with our other listeners.